Okay. Once again, thanks very much, Louise. And the subject I'm going to talk to you about today is hypothyroidism, the unmet need. And like Louise said, I'm part of the Thyroid Research Group in the Cardiff University School of Medicine. Now, in the talk, in the next 20-25 minutes, I want to tackle these 5 issues, talk to you about the scope of the problem, how big is the problem, and talk to you about some of its features. And I want to talk to you about why we think some patients have persistent symptoms. And we believe that there is probably a lack of T3 in the tissues. But also talk to you that if lack of T3 is responsible for these persistent symptoms, why were the randomized controlled trials of combination therapy with T3 inconclusive? And I'll talk a little bit about what we need now and talk to you about the future, which I think is the LIONS D2 study. So first of all, I want to tell you before I start that levothyroxine, or thyroxine to give its common name, actually improves symptoms in hypothyroidism. So we need to get that very clear. This is a study from Denmark, a small study, which actually shows you that patients who have, these are symptom complexes in patients who've been given a treatment, the green lines, who've not been given treatment with thyroxine, and those who do not have thyroid disease. And you'll see that before treatment, and if you compare the situation before treatment and after treatment, there is a significant difference. And getting towards the center of the circle is improvement. Getting towards the outer periphery of the circle is deterioration. So you'll see that most of these symptoms around the circle actually did improve, but they did not come to the level of the yellow line there, which is normative data or data from patients who do not have thyroid disease. So thyroxine given to patients with hypothyroidism actually works. Right, so what about the scope of this problem? How big is this problem? We believe that in the UK, the prevalence of hypothyroidism is about 3 to 6%, and you know that. That means about 2 to 3 million of subjects in the UK have hypothyroidism, and that's a large number. But of them, we also believe that 10 to 15%, and that's a large number as well, have persistent symptoms, and as a result, a poor quality of life. And this is despite achieving what all expert bodies tell us to achieve, and that's normalized TSH while giving thyroxine. So not only do they have persistent symptoms and a poor quality of life, but there are objective findings which suggest that T3, which is the active thyroid hormone, is not actually active at the tissue level because they have a higher BMI. They weigh more than 10 pounds more than when they did not have hypothyroidism. They have a lower energy expenditure if you measure their energy expenditure using various techniques that we have. And they also seem to have other comorbidities associated with hypothyroidism, like hypertension, coronary heart disease, and hyperlipidemia. Now, we also believe that although the unmet need is great, we think that this is likely to increase because of several reasons. One is that the UK population is gradually getting older. This is the median age of the population in the UK in 2001 compared to 2021. Now, these are figures from the ONS. So you'll see that the median age, the median is a figure or a measure of average. Don't need to worry about that too much, but you see that the median age increased from 38 to 41, 3 years in the space of 2 decades. So this will increase even further. And why is it important? It's important because we know that as we grow older, or as the population grows older, the percentage of the population with hypothyroidism or high serum TSH increases as well. Now, these are figures from the ENHANCE study in the United States, and these are very large numbers, 150,000, if I remember right. So at the age of, say, 29 or 30, the prevalence of high serum TSH levels were around 2 or 3%, like we have in the UK. But if you grow older to the age of 79 or 80, your chances of having an abnormal TSH is about 10% to 15%. So that means of them, there will be a percentage who will have persistent symptoms despite thyroxine treatment. And we also know that these days we tend to do thyroid testing very freely. But there are two other reasons why I think that the unmet need is likely to increase. And the first is that we seem to treat mild disease. This is a paper from our group which looked at the age, the thyrotrophin level at the time of the index prescription in about 30,000 patients. We saw that about 6,000 of them, or a fifth of them, started treatment when their TSH was less than 4. So those are the dark columns there. About another fifth of them, another large chunk of them started treatment when their TSH was below 10. So we seem to be treating mild disease. So if you put patients on thyroxine, then the percentage of patients who will have persistent symptoms will increase. But we also seem to initiate treatment at lower TSH thresholds. This again is a figure for median TSH levels at the time of the index prescription of levothyroxine. In 2001, the median TSH was about 8.8 or 8.9. But in 2009, within the space of a decade, it had fallen by 1 whole millunit per liter to 7.8 or 7.9. So there are 4 reasons why I think that the unmet need is going to increase in the future. And to prove that, we looked at the number of prescriptions that have been issued for thyroxine over the last 6 years or so. And this is actually accepted for publication in the Lancet, and as you see it soon. But we found that there was an increase of about 4 million, or it's a bigger part, about 3 million prescriptions, or a 9% increase in the number of prescriptions issued for thyroxine in those 6 years. So that proves the case, really. Okay, what are the symptoms that people have that give them a poor quality of life? And these are largely them. Fatigue and reduced energy in about 3/4 or a little more than 3/4 of them. Weight gain or inability to lose weight, again in about 70% of them. Memory, cognitive problems, often described as brain fog, in about 60% of them. And mood disorders in nearly half of them. Now you add this all up and you find that their quality of life is significantly reduced. Okay, so we know that this is a big problem. We know what the problem looks like, and we know that it's going to increase in the future. And then we need to find out, why do patients have persistent symptoms? And it's like the proverbial elephant and the blindfolded man. You can have as many views about this problem as the description of the part that you're holding in this picture for the blindfolded man. So there's no unanimity about why this is the case. But we believe that, we'll skip that, but we believe that low tissue T3 seems to be the major culprit. But some authorities say they have physical and psychological comorbidities. That's true. They have somatic symptoms and related disorders. That's true also. They have a thing called autoimmune neuroinflammation. That might be true, as one study showed. But I think underlying most of their symptoms is this issue about tissue T3 not being adequate for their purposes, giving them persistent symptoms and a low quality of life. Now, this is a new view. I'm afraid not. As you see here, in 1974, Stock and his colleagues published in the New England Journal a seminal paper which looked at patients on thyroxine and euthyroid controls, and showed that patients on thyroxine had a significantly higher T4 level and a significantly lower T3 level compared to controls. And this has been replicated in a more recent study where Jonkles and colleagues looked at patients who had a total thyroidectomy and went on replacement therapy because they were hypothyroid, and compared their TSH, T3, and T4 values to their pre-op data. And again, they confirmed that post-operatively, while on thyroxine, their T4 values were significantly higher and their T3 values were significantly lower compared to the pre-op status when they were clinically euthyroid. So have we taken any notice of their views? I'm afraid not, because if you look at the literature, there are about 14 or 15 papers, out of which 4 show that there's no difference or that T3 was normal. But the vast majority show that in patients who started thyroxine for hypothyroidism, they had low T3 levels after commencing treatment. And we believe that these 4 papers contained populations which are not large enough to demonstrate a difference. So we have been ignoring these findings for a long time. And you'll ask me, why are we worried about this T4, T3 imbalance? Why are we worried about a low tissue T3? And this is the reason. If you look at patients and their pituitaries containing TSH secreting cells, and you know about the feedback mechanism where if your thyroid hormones fall, your TSH increases and drives the thyroid again to produce more thyroid hormone. And if you look at the pituitary gland and their TSH secreting cells, in hypothyroidism, the expression of the deiodinase 2 enzyme, and again, I'm sure most of you know about the deiodinase 2 enzyme, that's the enzyme that converts inactive T4. So the thyroxine you take, if you're hypothyroid, is actually inactive. It's a prohormone. And tissue deiodinase converts T4 to T3, which is the active hormone. So if you look at the hypothyroid patients, this is before treatment, you will find that there's an enormous increase in the activity of TSH secreting cells because it wants to push the thyroid gland to produce more thyroid hormone. But if you add T4 into the equation, you will find that this deiodinase enzyme is being produced at much lower quantities when you're given free T4 thyroxine, and D2 activity, which is the enzyme, as I said, that converts T4 to T3, D2 activity falls. Okay, and that's the main reason why we are concerned about this imbalance between T4 and T3. If you don't understand this, don't worry, you'll have enough time to ask me questions. Okay, so therefore, could tissue T3 lack be responsible? Now, if you look at this diagram, I told you that the thyroid gland produces about 5 micrograms of T3 per day, which is only about 1/5 to 1/6 of total T3 production by the human body, because the rest is actually produced by the thyroid cells, I beg your pardon, by tissue cells from inactive T4. So the thyroid gland produces T4 as well, which is then transported to tissues and cells, and then into the cell itself by thyroid hormone transporters. And then within the cell, it's converted mainly by deiodinase 2, that enzyme we've been talking about, to T3. And you'll see from this diagram that it's only T3 that binds to cellular receptors and mediates actions of thyroid hormone. So however much T4 you give, if this transformation or if this reaction is inhibited, then you don't have enough T3 in your tissues to look after your tissues well. Okay? So there's indirect evidence for this. If you look at this large study from Italy by a chap called Gullo, who looked at about nearly 2,000 patients who were hypothyroid and were on thyroxine, he again confirmed the fact that about 15% of these patients had low free T3 levels, and about 7% had high T4 levels, again confirming in a large population study what we talked about earlier. And the T3-T4 ratio was lopsided in fully 1/3 of them. So there is a T3-T4 imbalance in large population studies as well. Could T3 lack be responsible? There's further evidence from animal experiments who were given LT4 alone or thyroxine alone, and they failed to normalize serum and tissue T3 when they were sacrificed and tissue T3 was measured. But when they were given the combination of T3 and T4, it normalized tissues and serum T3 both. Not only did they do that, they also normalize serum cholesterol levels and liver and muscle enzymes, which have also been disturbed by hypothyroidism. Is this physiologically plausible? Yes, it is physiologically plausible because of this factor, which I don't need to discuss really. But if you look at the deiodinase and transporter polymorphisms, that is genetic differences in the deiodinase enzyme, which about 13% of our Caucasian population have, we find that this is the polymorphism, the people who have 2 copies of that abnormal gene or who are homozygous for the polymorphism, their D2 activity is less efficient than the wild type or who are normal with regard to D2 activity. Their baseline quality of life is worse, but they have a better response to the combination of T3 and T4. And this is relevant to our trial, and I'll talk a little bit more at the end. And they also show that they have an increased preference for T4 and T3 in those with the combined D2 mutation and a transporter mutation. But I have to warn you that this is not replicated in all studies, and we can go into the reasons for that later on. So this is just a diagram showing you that the inactive T4 is transformed into T3, the active T3, by mainly the deiodinase 2 enzyme. And that's why we spend a lot of time talking about D2 polymorphisms. So if T3 deficiency is the cause for their persistent symptoms and poor quality of life, why were so many randomized controlled trials, and we got 18 of them so far, of combination T3 and T4 therapy inconclusive? They didn't show any superiority for the combination compared to T4 monotherapy. Now, these are the 18 randomized controlled trials up to now, which have looked at this issue about hypothyroidism, hypothyroid patients given a combination or LT4 monotherapy. I'm not going to worry too much about the 3 studies that were done in one trial studied DTE or desiccated thyroid extract. The other had patients with partial thyroidectomy, and the other hadn't disclosed what they treated them with, but had central hypothyroidism. So these are not the types of patients we are talking about currently. But there were lots of problems with these trials, and that's why I think none of them was conclusive. And one of the main issues was that they all used short-acting T3, and you know that all T3 preparations currently are short-acting. And these are not physiological. They're short-acting. When you take them, the serum levels increase in 2 to 4 hours, to supraphysiological levels, in other words, above what they should be, and they fall to about normal in about 4 to 8 hours. And for the rest of the time, you're free of T3. So there's no T3 in your body if you take it once a day. If you take it 2 or 3 times a day, which is very difficult for patients to do if they're on lifelong treatment, then you may replicate T3, normal T3 kinetics, but it's very difficult. So we need a new T3 preparation, and we'll talk about that in a minute. But these trials also had a small sample size. If you look at them, 26 here, 10 here, 28 here, 27, 26, and so on, and 32, and so on. So those are probably underpowered to detect superiority of T3, T4. And they were all of short duration. Again, 5 weeks, 5 weeks, 8 weeks, 8 weeks, 6 weeks, 5 weeks, and so on. So the majority of them were of very short duration. That's important because T4 has a long half-life. You know that the half-life of T4 is about 7 days. So if you mess around with T4 dosage, you need a long time for it to then again settle down to normal pharmacokinetics. They also used inappropriate quality of life questions. Now, I don't know how much you know about quality of life questionnaires, but we believe that a thyroid-specific quality of life questionnaire like the ThyPro questionnaire or ThyPro 39 questionnaire needs to be used in trials like this to elicit thyroid-specific symptoms from patients. Otherwise, you get a general picture, and that may not be appropriate. And finally, they also used inappropriate patients, we believe. And by this, I mean patients who may have had no symptoms. Patients who may have been well on their thyroxine or may have had mild symptoms. So there was nowhere to go really in terms of improvement. And there were others as well. So there were many deficiencies, if you like, in these 18 trials or 15 trials, if you remove the 3 in yellow, and we think we need to correct them. But don't forget, if you look at the 6 RCTs with low to moderate risk of bias, and there were only 253 participants in them, they showed that about 43% or nearly half of them preferred the combination treatment. A quarter of them preferred LT4, and nearly a third of them had no preference. So there was no clear-cut preference for T3, T4, although 43% said, yeah, they preferred the LT3, T4 combination. So, like I said, all current T3 preparations are short-acting. And again, there's a peak in 2 to 4 hours, which is supraphysiological. And then it drops off. And in about 8 to 10 hours, it's almost undetectable. And that's how it is going to be for the rest of the 24 hours. And there's a 200 to 400% variability of serum levels, which is no good. And how do you dose adjust? If you're a clinician looking at a patient who's taking T3 once a day, let's say, for the sake of argument, which level are you going to ask your patient to have in terms of T3? Are you going to take a trough level here when he or she has not had T3 for 10 or 12 hours in her system? Are you going to measure it in 1 hour here? You're going to measure it in 4 hours when her levels are supraphysiological? Or you're going to measure it at 8 hours? It's very difficult to decide. There's no way you can actually sample blood tests or sample blood for the purposes of dose adjustment. And like I said, to be physiological, you need to give it 2 or 3 times a day. So you have another peak and a third peak. But having said all that, there are 3 trials which looked at the long-term effects of liothyronine. One was Graham Leese's study from Scotland, where he looked at 400 patients who were on T3 and about 34,000 patients who were not. And he followed them up for 9.5 years. And he found that there was no excess risk of death or cardiovascular events, which is what we worry about, particularly if your T3 goes up in 2 or 3 hours. But there was no excess risk of death or cardiovascular events. There was a marginally increased trend for increased risk of breast cancer. But as you see, it was only marginal. Then there was a larger study in Switzerland. Again, patients followed up for 8 years, 11,000 patients compared to 564,000 patients, where they showed no increased risk of all cancers or breast cancer, and a reduced risk of all-cause mortality in the treated group. So that was a good response there. And another one in South Korea, where they looked at 1,400 patients compared to nearly 4,000 patients who were not on T3, on T4, and found that T3 patients had a higher risk of heart failure and stroke. But theirs was a highly selected group of patients because there was a 34% incidence of thyroid cancer in those who went on T3. But the message seems to be that T3 seems to be safe in the long term, even if you're taking the short-acting T3. Now, at this point, I have a confession to make. I was a non-believer till very recently, and I thought there was no place for T3 in hypothyroidism. And again, another confession, I had never ever prescribed T3 to one of my patients. And some of you know that I ran the tertiary thyroid service in Cardiff for, I don't know, 10 to 15 years, following on from Professor Lazarus. But then I had a Damascene conversion. I saw the light. And now I'm a firm believer. My change has been so profound that I debated Professor Colin Diane, who you know very well, and was against him. And the subject for debate was T3 is a valuable option in treating hypothyroidism. Professor Diane proposed that, and I opposed him in 2017. And after my conversion, I debated Professor Simon Pearce, who said you're talking rubbish, because I proposed that LT3 is a valuable option in treating hypothyroidism. So my conversion has been perfect. And I'll let you into a secret. I'm also the academic lead for the Lions D2 trial. So why did I change my opinion about T3? Firstly, because of inspiring and knowledgeable colleagues that I move around with, the chief of whom is Professor Diane, whom you know very well. The evidence was out there if you wanted to look for it. And the evidence was convincing, at least in my opinion and in the opinion of people I've talked to, that T4 therapy is not physiological given alone. It does not restore thyroid physiology. So what we really need now is this. We need a long-acting T3 preparation, because as I told you, all these trials that were inconclusive used short-acting T3. And I'm happy to report to you that we have 2 preparations, one of which was the PZL, or the polyzinc liothyronine of Professor Bianco's team. And he's had phase 1 studies already and showed that the pharmacokinetics of PZL, or PZL as they call it, was very favorable compared to short-acting liothyronine. And then we have T3 sulfate, which is our favorite. And this is a study in 2019 from Santini's group, which showed that if you give T3 sulfate, your T3 levels in the blood go up in 3 to 4 hours or 4 to 8 hours. But look at this. It seems to last forever and ever. When they stopped checking at 48 hours, the levels were still appreciably high and within the reference range for normal individuals. So we think we found the holy grail, and that is T3 sulfate. Now, if you look at international guidelines for treatment of hypothyroid, I'll talk a little bit more about T3 sulfate in a minute, but if you look at the international guidelines on treatment for hypothyroidism, and these are the organizations I'm referring to, they tell you that T4 is the standard of care, because you see that in the vast majority, normality is achieved. But we got to recognize, and we got to stop being cynical about the subset of 10 to 15% of the individuals who are on thyroxine treatment who do not respond to T4 alone. And these organizations also say that a combination of T3 and T4 may be considered in individuals who do not respond to T4 alone after the exclusion of comorbidities. And finally, they said more research is needed. And here we come in. The future is the Lions D2 study. Now, this is a randomized controlled trial with a crossover design. And you can see that in one arm, they would be on the investigational drug, T3 sulfate. And in the other arm, they would be on placebo with their usual thyroxine treatment. But after 24 weeks, so it's a long trial, they will cross over to the other arm and be given the opposite treatment. So the trial will last for 48 weeks or nearly a year. And with the screening and the recruitment and dose adjustment times, it'll last 58 weeks or 56 to 58 weeks or more than a year, and giving enough time for everything to if you like, stabilize. But we also felt that we need to be specific in our selection of patients. We want to select patients with the D2 polymorphism, which I showed you before. We also want to prove the principle that T3 sulfate improves symptoms and quality of life in hypothyroidism. We needed to get medium-term safety data for T3 sulfate. Medium-term, when I say medium-term, it's little more than a year. We needed to get pharmacokinetic profiles of T3S in these patients. Secondary endpoints, looking at the end result of T3 action in tissues, like energy expenditure, like lipid levels, like, like day profiles, and so on. And like I said, the design is a randomized crossover trial. And the advantage of having a crossover trial is that the patient who is involved in this is his or her own control. So we don't need to go looking for other patients who may not be the same. So the patient himself or herself is his or her own control. Right, why choose patients with the D2 polymorphism? And I've told you something of this a little while ago. It's because if you look at the patients who have the homozygous variant, or they have 2 copies of the abnormal gene, they start off at a higher level of symptoms compared to those who are heterozygous or normal. But their drop in their GHQ score or improvement in quality of life is much greater than these 2 groups. So we have a group who will respond nicely if they're going to respond to the T3 sulfate that we are going to give them. And where are we getting our patients from? We are going to recruit them from another study we are running at the moment called the GenThyre study, or the Genetics of Thyroid Hormone Replacement study. And we've genotyped, actually we genotyped more, we genotyped about 1,400 now, but we got about 14% of that who had the CC genotype or homozygous for, or 2 copies of the abnormal gene. And we want to go to patients who have, who are on 100 micrograms per day of thyroxine or more. And again, 51% of this will be on 100 micrograms or more, because if you look at patients who are on 100 micrograms or more, their chances of responding, that's the column there, is much bigger than if their thyroxine dosage was less than 100 micrograms per day. In other words, their thyroid deficiency is more or less complete if you're on 100 micrograms per day or more. So concluding, I think I've overrun my time, but concluding, we know that there is a significant unmet need in T4-treated hypothyroid patients. I think we are convinced that T3 lack or tissue 3T lack is the major reason for their symptoms. We found from studies which we've not done, but other people have done, that long-term T3 seems to be safe, although they used a short-acting variant. But we know that previous studies of combination therapy were inconclusive because of design issues, and I've gone through some of them. And we need a T3 which mimics natural T3 profiles. And we think we found two, PZL from the American group of Professor Bianco, and T3 sulfate from Professor Santini's group, but which we are going to use in this well-designed, although I say it myself, randomized controlled trial incorporating the above. Now, I just say thank you to all my colleagues in the Thyroid Research Group, and you know most of them. So I leave you with that picture of that rainbow, and at the end there will be T3 sulfate and Lyons D2. Thank you very much.